Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast.
Hello, everybody. I'm Dr. Ben Weitz. Thank you for joining our functional medicine discussion group meeting. I very much apologize for no food tonight. Unfortunately, Chops Eatery, who we ordered the food from, decided to go out of business yesterday. So sometimes stuff happens. I hope you'll consider attending some of our future meetings. Next month, we have Dr. Darren Ingalls, who's going to be speaking about Lyme disease, and that's going to be June 27th. July 25th, Alan Berry on hypothalamus, pituitary, adrenal excess. September, we don't have a speaker yet for August. September, we have Dr. Pimentel. So I encourage everyone to participate and ask questions. And if you're not aware, we have a closed Facebook page, the Functional Medicine Discussion Group of Santa Monica. So you can join there and we can continue the discussion. I post a lot of research studies there and have discussions about functional medicine. I'll be recording this event and I'll be posting it as part of my Rational Wellness Podcast. And you can find that on Apple Podcasts, Spotify, YouTube. So if you listen to the Rational Wellness Podcast, please go to Apple or Spotify, give me a 5-star ratings and review. And our sponsor for this evening is Integrative Therapeutics. So I'm going to ask Steve Snyder to come and tell us about a few integrated products. Thank you, Steve.
Thank you. Hello. Thanks for coming. Glad to be here.
Oh, hold it close to your mouth.
Okay. So the topic is constipation, right?
Yes.
That's not a huge thing for us. We had a great product called laxative formula. Unfortunately, we discontinued it. We do have a really nice formula called motility activator that works as sort of a almost like an adaptogen for the gut. And so whether you tend towards loose stools or constipation, it actually helps with both. It's a high potency ginger and artichoke extracts. It's a great formula. We sell a lot of it. That's kind of it right now. So maybe Dr. Ravar I'll listen and learn something tonight and we'll come up with something new. Also in the back, we have a couple new ones. There's a vitamin D with K that's new. We kind of got into this late, which is how we kind of roll. But this is a good thing because we waited till sort of the science was clear on which nutrients and how much to use. So it's a really, really good formula. And it's 5,000 IUs of vitamin D, 180 micrograms of K2, and it's about half the price of K-Force. So if you use K-Force, it's the same formula at about $25. We also have a brand new mag-threonate that I don't even have. It's that new. It came on our website today. That one is also going to be similar. It's a high potency mag-threonate with a low cost. And then we have samples of cortisol manager, which you guys all know about, and also the new curcumin, which is called Curaleaf. So get those.
And then, of course, one of the main causes of constipation is methane SIBO, and you guys have the elemental diet.
Yeah. So we talked a little bit about the elemental diet. This is not the place. There's too much to go into with the elemental diet, but it's the only real one out there right now. I guess Mark Pimentel's come out with one that's close, but it's super high in carbs. So if you're interested, somebody already did tonight, talk to me about the elemental diet. We also have, last one, we have a product called Blue Heron. And it's an oldie but a goodie, and the reason it's called Blue Heron is because blue herons poop a lot. So if you happen to want to try that one, it's something we can talk about too. So there you go. Thanks for coming.
Thanks, Steve. And so our speaker for tonight is Dipti Sagar, and she's a integrative gastroenterologist who works with Dr. Sam Brevard. And so why don't you go ahead and introduce yourself, Dipti, and get started. Thank you.
All right. Can you guys hear me okay? Yeah? Okay, so a very good evening to everyone. This is such an honor presenting here this evening, not only because I get to meet like-minded physicians like you all, but because of how profoundly this has affected my life as a physician. I first got introduced to holistic integrative medicine when, after several years of practice as a gastroenterologist, as a medical director in a big county hospital, doing thousands of endoscopies and colonoscopies, and giving PPI to my patients like candies, I realized that a lot of my patients were not getting better. So that made me look into what we are missing in traditional medicine. So I started to dig deeper and wanted to see some non-traditional ways of treating my patients. And then I had my own journey where I started having GI issues. Yes, a gastroenterologist with heartburn. And very quickly I realized that I cannot take those medications that I was prescribing to my patients. And that really put me into this path to explore non-traditional ways of healing. And I started this 2-year fellowship with Academy of Holistic and Integrative Medicine, where I really learned a lot, but unfortunately I could not bring those concepts into my previous practice. But that said, I do believe that when you have an intention, the universe makes it happen for you. Just like we didn't have a laptop today, but someone just walked in with a laptop. So when you have the intention, it happens. And I guess that's how Dr. Rabar and me found each other. And we started this collaboration together to do our practices together because of similar mindset. And I'm really so very grateful for that collaboration because it has infused love, passion, and life in medicine for me. And I really call this my rebirth as a physician. And to my surprise, my patients were very accepting of this kind of a model where I'm combining traditional medicine with holistic and complementary medicine, because I thought I'm going to get so much of pushback from my patients. But instead, they looked at me and said, "What took you so long? This is what we have been waiting for all along." So really, it changed my relationship with my patients as well. So without further ado, because I know I have to condense my 15 to 20 years of experience treating constipation into just 60 minutes, and now I actually have only 55 minutes, so let's begin.
Well, we have till 8 o'clock.
All right, so I'm going back, let's see, there we go. So my collaborators for this presentation is Dr. Rabar and Dr. Edmond. So as a gastroenterologist, I can very well relate to the first statement, which is no organ in the body is so misunderstood, so slandered and maltreated as the colon. And as physicians and providers, some of you probably working in a hospital setting could relate to the second statement that besides death, constipation is the big fear in hospitals. So what is the goal of today's presentation? We are going to understand the pathophysiology of constipation. We're going to learn about diagnosis, management, presentation and pattern recognition, association with gut microbiome, as well as other illnesses. And we're going to understand the principles of management. Let's talk a little bit about the disease burden. So it affects about 10 to 20% of the population. And to be honest, it's very underdiagnosed because a lot of the patients, they don't even come to physicians for this, and they just think that this is normal or they just have to live with it. So this is just reported 10 to 20%. It does affect the quality of life in a similar way to congestive heart failure or rheumatoid arthritis. About 700,000 individuals present in the ER for constipation every year in the United States. And can you imagine, like 10 billion is spent annually on laxatives. Okay. So when a patient walks into your office, and probably your 10th or 15th or 20th patient of the day, and they say, "Doc, I'm constipated," that's when all hell lose break, right? And you're like, I'm ready to quit medicine, right? But to be honest, it doesn't have to be that way. And today I'm going to equip you with tools that you can use so that you know exactly what questions to ask this patient, what tests to order, and how to manage them so that it doesn't have to be that difficult. So when you walk out of this room today, you'll be more confident in taking care of these kind of patients, okay? So as we discussed, constipation is common, but it is challenging, and we have to have a systemic approach in evaluating these patients so that we can treat them effectively. However, I wish it was this easy. It's not. So, what are the few questions that you're going to ask the patient? I'm going to give you 2 questions, which is going to kind of open your mindset as to which direction you would be going. The first question is an infrequent passage of stools. That means they are not moving their bowel every day, or they are taking 2-3 days to move their bowels. If that's happening, if the patient says yes, then you have to stop thinking about slow transit constipation. That means the transit of the colon is not as well. The second question is, do you have difficulty with evacuation? Because if this is the problem, that they are not able to evacuate, then the problem is not because of the transit, but you have to start thinking about obstructive defecation. And one of the most common one is pelvic dyssynergia. I'm going to go into details of all of this, but these 2 questions will kind of help you understand which direction you have to go. Also remember that constipation can be a distractor. That means there could be a lot of underlying chronic systemic conditions, the presenting symptom of which is constipation. So you have to explore that. Just don't think it's constipation and just laxatives. We have to do more tests. We have to dig deeper into the root cause of that constipation. So this is a simple list, but it's not complete, as you can see. There's a variety of conditions that can cause constipation. It could be hormonal imbalance like diabetes, hypothyroidism. It could be problems with the pituitary. Honestly, this medication list is pretty short. It's not a complete list, but these are the common medications that can give constipation. So you have to ask the patient, did you change your medication recently? Is there something new that was added? And even old medications can take like a year or so, like calcium channel blockers, to have constipation. So we have to take that history. Neurological disorders like Parkinson's disease, spinal cord disorder, myopathic disorders, and of course we have to think about structural disorders like colon cancer, rectocele, things like that. So what's the next question? Is this chronic constipation? Is it because you were admitted to the hospital, had a surgery or a C-section, and you got morphine? Maybe that's why you're constipated. Then that's not chronic, right? That's related to the opioid, and it's acute. So how would you know if it's a chronic constipation? Well, if the constipation is present for at least 3 months for a duration of 6 months, that's how we define chronic. And if it's chronic, then you have to ask this question: is it functional constipation or is it IBS constipation? I actually got this slide from Gastro of 2020, and it summarizes very nicely what is the difference between functional constipation and IBS constipation. So with functional constipation, about in 25% or more of the times, they will complain of staining, lumpy stool, sensation of incomplete evacuation. Very important, use of fingers to disimpact yourself. This is extremely important, and especially I see this a lot of time in women, and I'm passionate about it because middle-aged women, they will come to you saying that they've been constipated all their life. And it started at the age of 18 and they have never had a regular bowel movement. The very next question that I always ask them, do you ever use your finger to disimpact yourself? And if the answer is yes, you already know that you're dealing with an obstructive defecation, most likely pelvic dyssynergia. Okay, so that's one point. And then in those cases, you will never have loose stool. They will always complain of hard, lumpy stools. As compared to IBS constipation, where it will always be associated with some kind of abdominal pain, which is relieved with defecation. The stools would be either infrequent or inconsistent, and about less than 25% of the time, they will say that they have loose stool. So loose stool is present in IBS, but not in the functional constipation. So the chronic constipation could be either normal transit, slow transit, dysenergic defecation, or it could be a combination of two. It could be slow transit with dysenergic defecation. So a little bit about the slow transit. It is also called a lazy bowel syndrome. And as we said, there is decreased motility of the colon. The etiology is really very poorly understood, but there could be a lot of things at play, like lack of fiber. It could be autonomic neuropathy. The interstitial cells of Cajal are actually the colonic pacemakers, and sometimes abnormalities of those can decrease the motility. And we cannot undermine the role of neuroendocrine system like pancreatic polypeptides, serotonin, because those also play a role in the colon's motility. This is different from obstructive defecation, as I said, pelvic dysnergia, especially in women. There is a problem with the pelvic floor which cannot relax, or it could be a spasm of the anal sphincter. Decreased rectal sensation, where even though stool is present in the rectum, they don't feel the urge because the sensation is less. So that can also happen. And then weakness in the pelvic floor, if they have multiple vaginal deliveries, difficult childbirth, they could have things like rectocele, internal prolapse. And when you have these things, they can either cause a physical blockage to evacuation, or sometimes they form these pockets and that trap the bowel contents, causing obstruction. So how do you identify patients with primary functional chronic constipation? So again, as we said, thorough history taking, asking them everything, when it started, frequency, medication. The visceral stool chart, honestly, we should all have this in our office, a big one on the wall. If you don't have it, please carry it in the size of a pocket, a picture. The reason is that I feel like whether you're having soft or hard stool is a very relative term, which is soft or form for one person can be like a loose stool for another. So this picture kind of generalizes it so that it's very uniform for everyone. And if your patient says that the stool looks like type 1 or type 2, you have to start thinking about slow transit constipation. Because why? That means the stool is passing through the colon for a long time. And what is the role of colon? To absorb water from the stool, right? So if it stays in the colon for a longer time, your stool is going to get harder and harder, and that's why they have type 1 and 2. Then you have to think about slow transit. The third thing that you have to think is, I cannot actually tell you how important a pelvic floor and anorectal exam is that you need to do on all your patients with chronic constipation. And I'm going to tell you 6 points that you need to look when you're doing that rectal exam. That's going to give you so much clues as to what's happening with the patient. And then ultimately, you have to do the anorectal manometry for these patients to differentiate slow transit from pelvic dysnergia, and we're going to talk about that as well. So digital rectal examination. So the very first thing is inspection. So even before you put the finger into the rectum, you have to separate the cheeks with both your hands and look around. What are we looking at? We are looking at external hemorrhoids. Is there a bulge? We are looking for internal hemorrhoids which are prolapsed. We are looking for any irregularities, because then you have to start thinking about the rectocele. You have to look at the vaginal area. Is there a vaginal prolapse? You have to look at if there is a scar. Are we dealing with the anal fissure? Are there holes around? Are we looking at fistula? Right? So inspection is very important. We look at those things. The second thing is sensation. So we are going to do the anocutaneous reflex. So usually I use a Q-tip. So one end has a cotton and the other end is like wooden. And we are going to check that sensation in all the 4 quadrants at 9 o'clock, 12 o'clock, 3 o'clock, and 6 o'clock positions. And if there is a contraction of when you do the reflux, then it's normal. However, if you don't see any contraction of the skin, then you use the wooden side. And if you see contraction now, then it is abnormal or impaired. And the absent is when even with the wooden side, you cannot see any contraction. Next is palpation. So when you insert the finger, you have to see the consistency of the stool. Is it hard stool? Is the patient impacted? If yes, then yeah, you're thinking about obstructive defecation. Is there liquid stool? Or is it no stool? So patient is constipated, but there is no stool. So yeah, this is slow transit constipation then, because the stool hasn't come to the rectum yet. So that gives you some clue. And if you have done enough rectal exams, you would know what a normal resting sphincter tone is, right? So that is something that we need to feel at rest. And after that, you tell the patient to squeeze very hard for 30 seconds because you're checking if they have enough strength, if there is enough squeeze there. If not, you have to start thinking about problems with the sacral nerve and probably get an MRI. The next, we are going to ask the patient to push down, thinking that your finger is actually a stool and they have to evacuate it. Before the patient starts doing that, you have to put the other hand onto the patient's belly, okay? And then you ask them to push down. When the patient is contracting the lower abdominal muscles, the sphincter in your finger should feel relaxed, right? However, if there is opposite, that means the sphincter is tightening and the abdominal muscle is relaxing, it's a problem. If both of them is relaxing, that's a problem. If both of them is contracting, that is also a problem. So if you see any of this, you already is thinking in terms of pelvic dyssynergia, and the next step would be to do an anorectal manometry. So when you do the push down, you have to see what's the push effort. You have to see if the sphincter is relaxing or not. And you also see if there is a perianal descent or not. So balloon expulsion test is a useful test that I recommend doing it in the office. We do it combined with anorectal manometry, where you insert a balloon with a catheter and fill the balloon with 50 ml of water. The patient is supposed to expel it within 60 seconds. If they are not able to do it or take longer, then again you have to start thinking about pelvic dyssynergia. We always combine this with anorectal manometry in our office setting. I'm not going to talk about that because Dr. Edmund is going to go into the details of how we do that after my talk, so you'll get some overview there. Let's get to the cheese of it, the treatment. So if you have diagnosed the patient with pelvic dyssynergia, we recommend doing a pelvic floor physical therapy. There are several exercises that we can recommend to the patient to strengthen their pelvic floor. And I know I said women, but men can also have pelvic floor abnormalities and dyssynergia. So there are critical exercises for men as well that we recommend to our patients. This was a good study which was published in the Clinical Gastroenterology in 2023, an office-based point-of-care test that predicts treatment outcomes with community-based pelvic floor physical therapy in patients with chronic constipation. It's very interesting that they use this special balloon, and it's a foam-based balloon. As you can see, when it's deflated, it looks like that, and then you inflate it with water. The benefit of this is that the consistency feels like that of stool. So it doesn't feel like water or air for the patient, so it's more natural for them because it has the consistency of stool. I always believe in going back to the basics before we start, the big guns. So lifestyle, we always start with this, right? Are you drinking enough water? 60 to 80 ounces of water or fluid every day. Are you getting enough exercise? Because if you are moving, your colon is moving. Are you having enough fiber in your diet? Start small. I start with one fruit every day. So I tell the patient maybe have one apple, plum, apricot, any fruit which is like high fiber with the skin for breakfast every day. Start there and see how you do. Because sometimes that's enough, And then this is something which I always encourage my patient, that a lifestyle change which is free of cost. And trust me, your patients their ears will be all open. They want to know what that is. You ask them to drink a big glass of warm water every morning. Okay, so you don't have to buy anything, it's free of cost, but it's so helpful for patients with constipation. What it does is, because the water is warm, it's going to cause vasodilatation, so it's increasing the blood circulation to your gut, right? And secondly, because it's warm, it's also stimulating peristalsis. So extremely helpful if the patient is kind of dealing with a slow transit kind of situation. Fiber, I'm especially a big fan of bulk-forming fiber, but remember, not all the fiber is the same. There could be soluble fibers and insoluble fiber. Psyllium is my favorite. It is also a prebiotic because it's broken down by your gut microbiomes into postbiotic metabolites like short-chain fatty acids, which in turn is helpful for gut-brain, gut-lung, and gut-liver axes. So extremely helpful. The patients have to drink enough water with the fiber for them to work. And remember that fiber can sometimes cause gas and flatulence. So not every fiber is good for everyone. So your patients have to try different ones to see which one works best for them. So outlet obstruction, again, we talked about high fiber will work for those patients as well, because sometimes the sensation in the rectum, as I said, is decreased. So your job is to bulk up the stool so that the rectum is stretching more than usual, so that they have the sensation that now they have to go. So that's why even fiber works in outlet obstruction. Sometimes we do warm water rectal irrigations. Biofeedback, very helpful in patients with anismus and reduced rectal sensation. This is something we offer in our office setting as well. Botox injection into the puborectalis, psychological counseling, pelvic floor rehabilitation, as I said. Surgery is the last resort, but you have to remember that about 50% of your patients will have recurrence of symptoms in 4 years. And therefore, again, going back to the basics and doing the basic stuff is more important. I usually get asked, like, when I'm going to order the MRI. Honestly, whenever you feel that there is an organic abnormality, like you're thinking about a rectocele or a prolapse or intussusception, that's when you get an MRI. A few words about the laxatives. Osmotic laxatives really works well. Magnesium is one of my favorites. And the Dococet is actually a lubricating laxative, but only use that for a short term. I do not like to put the patients long term on that. And really, stimulant laxatives like Senna and Dococet, they can cause a lot of cramping, so I usually don't recommend that. And you can use the rectal forms too, if that's what is preferred. A few words about magnesium, because I love magnesium, but you have to remember that not all magnesium salts are the same. So if the patient is having a constipation problem, we prefer to give magnesium citrate or oxide. But some of my patients, for example, my all-time favorite is magnesium glycinate, and especially in middle-aged women, in perimenopausal women, somebody who's like 50 years old, having constipation, but at the same time they're having perimenopausal symptoms like hot flushes, anxiety, not able to sleep at night. I always combine magnesium glycinate because it has a very calming effect on the nerves, especially in that patient population. So if you combine magnesium citrate with magnesium glycinate, in those patient population, you will see significant improvement, not only in terms of constipation, but also relaxing the pelvic floor because it has a calming effect, the glycinate. So just a few words about the medication. So we have anesthesia, lenses, Trulens, and vertegrate. I'm just going to say that all of this works by increasing the colonic transit. So honestly, if you are having a patient with slow transit constipation, you can consider them. Definitely, they are peptides. But remember, we always need to have a discussion with the patient, and not everyone is ready to try medications. If by your physical examination and your tests, you have established that this patient has pelvic dyssynergia or obstructive defecation, you do not want to use this because there is no problem with the colonic transit in those patients, right? So be very careful because if there is an obstruction and you use this, it can be very uncomfortable for the patients. Again, they are not without side effects. Sorry, the slide is not very clear, but this is published in 2007, the side effects of anesthesia, like abdominal pain, cramps, diarrhea, flatulence, lenses, and Trulens, same kind of a side effect. This is the new kid on the block, IBS Rila. It is minimally absorbed, and it's a small molecule inhibitor of sodium hydrogen exchanger isoform 3. It is recently FDA approved for IBS constipation. You give 50 milligram twice a day with meals. And again, it has side effects, diarrhea, flatulence, and nasopharyngitis. So this is another option that we can use. So as a holistic gastroenterologist, I always try to think out of the box. What is it else that I can offer to my patient, which is not medication, has less side effects and more effective? I'm going to share some of my tools with you. And this is one of my favorites, it's Triphala. If any one of you are familiar with Ayurvedic medicine, you would know that this is a very potent herb which is used in Ayurvedic medicine. It's a combination of 3 herbs, Haritaki, Vibhitaki, and Amla. And it's used in Ayurvedic traditional medicine for years for treating constipation and inflammation. I'm very fascinated with Ayurvedic medicine. So if you know about it, in Ayurvedic medicine, you classify individuals based on their dosha. And the doshas is kind of their personality or how the body works. And there are 3 types of doshas: Pitta dosha, Kapha dosha, and Vata dosha. And as you can see, Triphala kind of works in all the 3 doshas. In fact, in India, Triphala is not only used for constipation, it's also used for weight management. So people use Triphala to lose weight very effectively without any side effects. So I offer this to my patients. Usually it's taken half to 1 teaspoon. You have to drink it with warm water, especially if you are treating constipation. At night time, it's great. It also comes in pill form. I do like powder form, but if you're doing the pill, it's like 750 milligram or something like that. But it has no side effects, very potent. The other one is use of MCT oil. So MCT oil is the same as coconut oil, but it has the medium chain fatty acids, which is more potent because it has 90 plus as compared to coconut oil. And how it works by loosening the stool and lubricating the lining of the colon so that it's easier for them to pass the stool. Vibrating capsule, this is another service that we offer in our office as well. This was a study that was published by Rao in Gastroenterology in 2023, and they showed that vibrating capsule was superior to placebo capsule. It improved constipation symptoms and quality of life, and it was very safe and well tolerated. The patients inject 1 capsule for 5 days in a week. And this study was for 8 weeks, and they showed that they improved bowel movements to 1 to 2 bowel movements every week. So the most common side effect of the vibrating capsule was the sensation of vibration, which 11% of the patients felt, but none of them quit the study because of that sensation, so it wasn't that bad. However, you have to keep in mind that there are some contraindications. For example, you cannot give this in pregnant patients. If the patient is needing a lot of MRI studies, what you recommend is that patient should be able to evacuate all the capsules before they go for the MRI. And for the same reason, because of obstruction or a diverticulum, you don't want the capsule to get stuck. So you have to rule that out before you give it to the patient. And remember that the capsule has to reach the colon to start vibrating for it to be effective. So if your patient has gastroparesis, that will not be a great candidate because it will not be like the capsule might start vibrating even before they go to the colon. So you want to exclude those patients. And then those are nerve stimulators, pacemaker, and defibrillators. You don't want to give them those. This is a study showing the benefit of naltrexone, which is a opioid antagonist in patients with cancer. So more opioid or morphine-induced constipation have shown benefit with that one. I'm a strong believer of the brain-gut connection, the vagus nerve. So it has an origin in the brain and it goes all the way into your colon. The rectum, however, is innervated by the sacral plexus. However, I do believe that there could be sometimes a miscommunication between the vagus nerve and the sacral plexus. They are not communicating very well, and that can cause constipation. And as you can see, the vagus nerve can aid in digestion, it can increase gastric juice, it can promote gut motility. So yes, if you stimulate the vagus nerve, your patients with autonomic neuropathy or decreased parasympathetic tone could actually have improvement in constipation. So this is a stimulator that we also offer in our office, very easy to use. There are several locations. There is another study which is showing the benefit of transcutaneous auriculovagal nerve stimulation on abdominal pain and constipation in patients with IBS constipation. So you can use the vagus nerve stimulation either in the neck or the yellow circle around in the ear. You can use there to stimulate the vagus nerve. But do you really need a device to stimulate the vagus nerve? Not really. You can tell your patients to do these things that will stimulate vagus nerve activation, like meditation, exercise, singing, massage, cold plunges in Lake Tahoe, splashes of cold water, breath work, yoga, intermittent fasting, and just hugging each other more often is going to stimulate your vagus nerve. So we have been pooping the wrong way in America all along, right? So the right way to poop is by squatting, because when you're sitting, The pubis rectalis muscle has an acute angle, as you can see here. So it's really difficult for the stool to go all the way when you have that acute angle. And that angle really becomes straight when you're squatting. So I really, for all my patients with constipation, I tell them that they should be squatting because squatting is the only natural defecation process. And we should really be doing this. Sometimes there is a deficiency of bile in your gut, and that can cause constipation. And there comes the role of a bile acid transporter inhibitor when I feel like this is the cause, because this medication can decrease ileal bile acid absorption and increase the colonic bile acid. And that in turn is going to accelerate the colonic transit. So this was a study that was published in Practical Gastroenterology by Virginia Schur about almost a decade back. And she talked about the Bell's palsy of the gut. So when you have Lyme disease, you have Bell's palsy, which is the paralysis of the seventh cranial nerve, and you have this drooping of the face. And the similar kind of presentation can happen in the gut, where the nerve endings get paralyzed and doesn't move as well. So in all patients with constipation, please ask them about the history of Lyme disease. Like, did they have a history of tick bite? Did they go hiking, camping, and had any target lesions? Because, the constipation in Lyme disease is a real deal. There are other studies here which are showing kind of a similar presentation of Lyme disease as constipation.
Could I ask a quick question?
Yeah.
With respect to bile?
Yeah.
What about the use of herbal bitters to stimulate bile production, or using ox bile as a supplement?
Absolutely. Yes, you can definitely use bitters, and we use that in our clinic setting too. You can use that to stimulate the production of bile. Absolutely. So use that. But that's another option that I showed you. Does that answer your question?
Yes.
Okay. Very good. So not only constipation, but as you can see, Lyme disease can cause other GI symptoms like bloating, abdominal pain, irregular bowel movements. So always keep that in mind, just like whenever a patient with multiple GI issues comes to your clinic, stop thinking about Lyme disease as well. Lead poisoning is another one. It can cause constipation. So any patient with constipation, I always check their venous lead levels to see if lead toxicity is the cause. Autonomic neuropathy, again, can cause constipation, and the treatment is really sacral neuromodulation. So in patients with Parkinson's disease and Alzheimer's disease, we have to think of that. And then the gut microbiome. This is really important because they are the keystone species in the ecosystem. And these are the organisms that really help define an entire ecosystem. And not only the gut, but several organs in your body has microbiome, including your hair, nostrils, skin, vagina, oral cavity, esophagus. The composition of the bacteria is very different. For example, in your skin, there is more actinobacter as compared to your colon, which has more bacteroids and fumicatus. So it's very different, and it's like really a whole ecosystem there. However, the gut microbiome is affected by a variety of things. It can be affected with your diet. We recommend a high fiber fermented diet if you want to improve your gut microbiome. It's also related to physical activity. Use of antibiotics is going to affect it. Hormones, for example, if a woman is on oral contraceptive pills, it's going to affect their gut microbiome and may cause constipation. Stress, because when you're stressed out, the gut releases CRF, which increases the cortisol level and downregulates your immunity, and thus making you more prone to staph infections. Early life trauma, if you have pets, the use of prebiotics, heavy metals, and the pesticides like glyphosate, all of this can affect your gut microbiome. This is a very small list of what a disruption of gut microbiome can do to you. I don't have, this is beyond the scope to kind of list everything, but this is just a small list. And really, when you have a disrupted gut microbiome, which is producing a lot of methane, there is an immune dysregulation that happens, and immune suppression associated with vector-borne illnesses like Borrelia, Babesia, and bowel tunnel can happen. For example, if you have a methane-producing bacteria, Methanobrevibacter smithii, that is really linked to constipation. And that methanogen can also be seen in colon cancer, in colonic polyposis, in ulcerative colitis, and in diverticular disease.
Can I ask another question?
Yeah.
Methanobrevibacter, so that shows up on a stool. We do a lot of GI map stool tests,
Mm-hmm.
and methanobrevibacter shows up.
Yeah.
Ideally, it should be below detectable levels, but very frequently it'll be above that. It may not necessarily be in the red.
Mm-hmm.
Is that something that we should be concerned about?
Very good question. So we never look at one thing only, right?
Of course.
So it's always a whole clinical picture. Whenever we have a patient like that, you have to see what are the symptoms. Are they constipated? Are they bloated? Do they have a rash? Do they have food allergy? I would probably do a SIBO test. I'll probably look at the gut microbiome. I'll look if they have leaky gut syndrome. So a combination of all of that. And based on what you found, we are going to treat that. We never usually give antibiotics targeted to just that bacteria. But yeah, if you have a clinical picture of SIBO or SIFO or leaky gut, then we do address that.
Right, because there's a bit of a controversy now about methane SIBO or EMO, because now it's recognized that it can exist not just in the small intestine, but in the colon as well.
Yeah, it can.
And then the question is, is seeing methanobrevibacter on a stool test, can that be used to diagnose a methane SIBO?
I would say it would support the diagnosis, but you have to obviously combine that with breath test and the clinical picture. But for example, a lot of, like when I'm talking about bloating and constipation, so everything is a sign, and then you have to combine those the
Right.
points that you collected to
Right.
make your clinical judgment.
Right.
So if you see something like that, definitely that's going to alert your mind to see if this is like a methane SIBO, and you're probably it's going to prompt you to do further testing, like a breath test, for sure.
When you do the breath test, do you recommend 3 hours or 2 hours?
We do it for 3 hours.
For 3 hours,
Yeah.
okay.
It's 2 hours.
2 hours.
2 hours.
Yeah.
Because there's this whole issue, how do you diagnose methanobrevibacter overgrowth, EMO, in the colon?
Mm-hmm.
So we would either need a stool test or we would need a 3-hour breath test.
I don't have a microphone, but I speak loud. I mean, as you put everything together, it has never been a necessity to check the colon.
Yeah.
I mean, I've talked to other GI doctors, I don't find it very helpful to go to 3 hours just to look for excess methane. There would be some other indicators that methane could be a problem. The other thing I think Dipti is probably going to touch base, Methanobrevibacter smithii is an anaerobic microbe. And you have to remove the oxygen from the gut environment. And generally, when you see this, always look for a fungal marker. You're going to either see it on organic acid, you're going to see it on the same GI map, you're going to see it on stool culture, you're going to see fungal antibodies, or the clinical picture basically speaks of that scenario. And just as another comment, I practically would never treat a SIBO with methane directly targeted towards the SIBO. We generally target the fungi first before we attack the methane. Okay? Because the potential for giving antibiotics and switching the microbiome to a more fungal predominant is very high. And if physicians follow the patient, they're going to see that the effect of the benefit from the SIBO treatment is generally temporary, is going to come up with some other recurrence if the fungus is not addressed.
So don't address them concurrently, address the fungus first with something like nystatin, or what do you?
Well, I mean, there are many ways to address that, and that probably is another hour or two to have a discussion.
Yeah.
But the short version is that we treat the fungi first with diet and the antifungals that would be appropriate for that patient, biofilm busters, and then if we plan to treat the SIBO, then I usually keep the patient on an antifungal concurrently. Otherwise, in my experience, you're going to get a microbiome switch. Fungi are more aggressive because of their behavior, and even though some of this is not completely the U.S. literature, but there's information out there from the Europeans that we have kept records with.
What's your favorite biofilm busting strategy?
How about we let you to finish up the presentation?
I have a treat for you at the end
Okay.
because you asked me that question.
Thank you.
All right, so let's get back here. So we have always had those patients who are constipated and they're also bloated, right? So that's like a perfect combination. But remember that not all bloaters are the same. And how do we differentiate that? So you would have some patient who would have constipation and bloating, but they will also say that I always have rumbling, like my stomach makes so much of noises that my partner who's sitting across the table can hear that, right? And then when you put the stethoscope into the belly of that patient, you're going to hear a lot of noises. As compared to silent bloaters, where they would say that they are pretty big, like bloated, but they don't hear anything, like there is no rumbling. And when you put your stethoscope into the belly of those patients, it's pretty silent. So that tells you that probably the colon is not moving as well as it should. So it is probably a slow transit. Again, there could be an upstream problem because the classic definition of SIBO is abdominal pain, bloating, constipation, and diarrhea. So if you have a patient who is constipated and bloating, I do recommend doing the SIBO testing. And again, a huge list of things that would indicate a SIBO breath test, including constipation. And I wanted to bring your attention to this, the yeast function, because when you have a fungal overgrowth or the yeast overgrowth, that can drive a Th17 response, which can sometimes protect from pathogens. But when you have a dysregulated Th17 response, it can cause inflammation, it can cause leaky gut, it can upregulate the immune system and cause autoimmune conditions and constipation as well. So we are going to have a case presentation just to kind of keep up our interests. So I have a very lovely 40-year-old female who presented with multiple GI symptoms. She had indigestion, constipation, dyspepsia, flatulence, malaise, fatigue, distension, so she was bloated, she had nausea. When we did the breath test, she had a methane SIBO test, which was abnormal. And then when we did the food allergy testing, she has allergy to multiple food items. We did the Heidelberg gastric pH testing, which showed some bile reflux and pyrolic insufficiency. The stool test showed some Klebsiella, so she has a dysfloric gut microbiome, and there was some candida in the stool as well. We did the urine mycotoxin screen, and she was highly abnormal. The gliotoxin levels were 18 times that of the normal. The line screen was positive as well. This is her endoscopy picture, and this is the stomach. Usually, the stomach should not have this yellow stuff. So this is bile. When you see that, it means that there is a bile reflux. And bile really has no business in the stomach. It is supposed to be going into the small bowel and downstream from there. So this patient, just to make you understand, the bile is produced over here. So for the bile to go back into the stomach, it has to pass the pylorus. And usually that's not the normal route. The bile should be produced and go down over here. So whenever you have a case like this, where patient has bile reflux and constipation, the upper GI and the lower GI, you really have to target the middle man here, which is the small bowel. So this patient was treated for SIBO, for fungal overgrowth, and she was also treated for SIBO. With that treatment, her constipation significantly improved. And there was a special thing that we used on her, which did not only address the SIBO, the fungal overgrowth, but also the constipation. So to answer your question, we used diatomaceous earth in her case. So diatomaceous earth not only helps with the SIBO treatment because it's a biofilm buster, but also with constipation. So what is diatomaceous earth? Well, we all love the ocean in Southern California, right? So when you go to the ocean and you look at the bottom of the ocean, there are these diatoms, and they are these crustacean organisms which were made into food grade and used as a biofilm. So it kind of detoxifies the colon and cleanses it. So the biofilm is disrupted, and also it helps patients with constipation. So this really helped our patient here. So take-home message is always do a thorough rectal exam in all your patients with chronic constipation. We have to stop thinking about pelvic dyssynergia because it is very common and underdiagnosed. We have to consider balloon expulsion test with anorectal manometry in all our patients. It's going to help you differentiate slow transit from obstructive defecation. Constipation is a very common problem, and sometimes it's a distractor. That means there is something else going on with the patient and they present as constipation. So we have to wear our detective hats and get to the root cause of what's causing the constipation. And we look for SIBO whenever you have a patient with abdominal pain, bloating, constipation, diarrhea, food allergies. Methane SIBO is associated with IBS constipation. And if you have a negative SIBO test in a patient with bloating, bile reflux, and IBS constipation, it may indicate the presence of a fungal overgrowth and SIBO. Thank you so much for your attention. And with that, I come to the end of my I'll be happy to take any questions, but I know that Michael has prepared some slides for anorectal manometry too. So in the interest of time, I'll have him come over and do his presentation.
Thank you for being patient. And I'm Michael Erdman. I work with Dr. Sagar and Dr. Rabat. And I'm going to give a very brief talk on anal rectal manometry, because that's what I do in the office. And it's very interesting when you have certain cases of chronic constipation. It's a very useful tool. So the purpose of my little brief talk is to make you very aware of why you should refer some of your patients for this test. That's the button there. So brief objectives, basically just to get that message across, the importance of ARM. And pretty much what Dr. Sagar was saying, 1 in 3 patients with the first-line treatments for chronic constipation fail treatment. They're the ones that you start thinking about, the indication of, wanting to assess their pelvic floor and to, get them an anal rectal manometry so that you can see if they have a functional defecatory issue. And why? And it's basically because laxatives and fiber therapies are not as effective as biofeedback and pelvic floor physical therapy. Dr. Sagar's already gone over this, so I'll skip past it. And also the buzzwords in a clinic, the digital facilitation of defecation. These things, you always think anal rectal manometry, pelvic floor, physical therapy, and biofeedback. The detailed rectal examination can actually pick up about 70% of cases of dyssynergia. And that's what an ARM machine looks like. And these are the types of tests that the ways that you can analyze a patient's issues. So the first thing you look at with ARM is the anal sphincter pressure, and then after that, their ability to squeeze and how effective the sphincter is at doing that. The next thing would be looking at the myenteric plexus and the recto-anal inhibitory reflex, which is abnormal in patients with Hirschsprungs, for example. The sensory motor response with hyposensitive patients that have a distended rectum. Rectal compliance, which is something that you see, that's all about the pliability of the rectum and whether, for example, elderly patients have a stiffer colon and patients with Hirschsprungs, for example, would have a more distended rectum. And then there's the defecation tests, which is all about dyssynergic defecation, which is the really interesting bit. So this is pretty much what you're dealing with ARM. You're looking at a lot of graphs, and there are 4 balloons attached to this catheter, and they're positioned posterior, anterior, left and right of the internal anal sphincter, and they're color-coded, and then the color codes come up on a graph. So when you ask a patient to squeeze, you'll see the activity of that, and you'll see the anal sphincter response. So a squeeze initially is a biphasic wave pattern. There's initially a big spike, and then there should be this prolonged duration when you ask someone to try and squeeze for 20 seconds. If they have problems with incontinence, they're not able to do that. This is actually a reasonable squeeze pressure. It's not too bad. This is a much better squeeze pressure. It's not entirely symmetrical, but they can sustain it for 20 seconds, so that's totally normal. So these are the kind of things I want you to see with what the testing is for your patients. Someone who has a low squeeze, that's a very poor effort of the squeeze, can be poor compliance. Then you start thinking neurological problems, damage to the sphincters. If it is poor compliance, they do well with biofeedback, which is something that we offer in the office. Whenever you look at someone's ability to squeeze, you look at the cough reflex as well, because you see them together. So a cough reflex, when you ask someone to cough, the abdominal pressure rises and then the anal sphincter muscle contracts. So it's intact with patients that have upper motor neuron lesions, and then it's not if it's a chordae equine lesion. So when you look at someone who has a poor squeeze and a normal cough reflex, you think it could be poor compliance or it could be a central motor pathway issue. And then the other way around, it would be, if it's a poor squeeze and there's no cough reflex, then you think an issue, for example, with the sacral reflex. This is a very high squeeze. Now you see this in male patients that have chronic pelvic pain. When they have a high squeeze, they usually have a very tight anus. I said that on camera. And you see that, and typically they also have type 1 dysenergic defecation, which is something that I'll show you. Rectal sensation is another part of the test. This is your ability to see how your patient has what they can feel as you inflate this balloon inside them, and the balloon gets bigger and bigger. And you say, let me know when you first feel it. Let me know when it gives you a desire to have a bowel movement. Let me know when you can't take it anymore and you need to run to the bathroom, and let me know if you have any pain. If they have pain, you stop. This is an example of someone who's actually hypersensitive because they had a desire to go, and then with a very similar pressure, they had urgency. You use this test to look for hyposensitivity and hypersensitivity. Hyposensitivity, they would not be able to recognize two of these sensory tests. For example, if they can't feel anything in the beginning, you see that with diabetes. If they don't feel a desire for, or urgency, for example, that's with constipation. So I'll skip this bit. The sensory motor response, that's when you inflate the balloon. Someone should have an urgent desire to go to the bathroom. If they don't, that's a sign of hyposensitivity. And then the myenteric plexus, which is that the neurons and ganglia in between the longitudinal muscles and the circular smooth muscles that work with peristalsis. There's a lovely test with the ARN, which is the recto-anal inhibitory reflex. When you inflate the balloon, what you should see is a relaxation of the internal anal sphincter. And this is how it looks. So you have a nice increase in the rectal balloon, it's been pumped up here, and then you see a decrease of all the anal sphincter muscles. This is a very good example of an intact rectal anal inhibitory reflex. And that's how it also shows itself with ARN. It's the same way. You can see all the internal anal sphincter muscles relaxing at that point there. Compliance, this is all about, like I was saying, the kind of ability for the rectal space to accommodate the increase of the stool in that zone. And it changes as we get older, and also with scarring to the rectum. And there's actually a higher compliance with megarectum and fecal impaction. And then this is what dysenergia looks like, which is really what our talk was all about in regards to ARN. So what should normally happen is you ask someone to push when they try and poop. They push, and then the anal sphincter muscles relax. So this would be a normal looking defecation on ARN. And this is how it would look on the report. Dysenergic defecation, there's 4 types. The first, this is type 1. It's where you ask a patient to push, and they can push really well, but the anal sphincter tightens up, right? So the pressure rises instead of falls, and that's very abnormal. Type 2 at the top would be they don't have a very good push, and the anal sphincter muscle tightens up inappropriately. Type 3, they have a very good push, and the sphincter doesn't really tighten up, it doesn't really do anything at all. And then type 4, nothing's working. They can't push, and they can't relax the anal sphincter. So this is a case that I had where a patient came in with a hugely abnormal squeeze pressure, reaching 300 points on a squeeze, which is super high, like could really damage your finger on a rectal examination. And he was very proud of that. And then, when he did his dysynergic defecation test, and I asked him to try and replicate having a bowel movement, the balloon inflates, and as he's pushing, you see the anal sphincter muscles are rising as well. So this is type 1 dysynergic defecation. So if I go back to where we were, that's what we're looking at here, right? So he had a type 1 dysynergic defecation with the balloon inflated and not inflated. So he came back and had biofeedback with us. Biofeedback is very similar to ARM. But they can look on a screen, so they can see they've got a catheter in the bottom, and they can push. And when they push, they can see the rectal pressure rise, and they can also play around with their pelvic floor and try and work out how to make the anal sphincter relax. The first time he came in was on the left, and you can see this was after multiple rounds. He couldn't quite get it. On the third session, he came in with a higher anal sphincter pressure than he did on the first attendance, but he had a perfect correction of his dysynergia, which is amazing, And these are patients who have huge problems pooping for a very long time, right? So moments like this are great. And that's the benefit of anal rectal manometry, that's the benefit of biofeedback. Typically, they do much better when they have pelvic floor physical therapy at the same time. And so then the balloon expulsion test we've already gone over, and I've already mentioned this. And Dr. Sagar already mentioned this article, but what was interesting, in addition to what's already been said, is it also mentions the importance of paying attention to squeeze pressure, squeeze duration, especially with an abnormal balloon expulsion test. It indicates a very good response to pelvic floor physical therapy and biofeedback. The problem with the reports is it's very, it can give you mental block trying to figure out what's going on. So Dr. Rabar and I, a couple of years ago, had enough, and we came up with our own version, so now whenever people come to see us for ARM, we send them home with a lovely report. It goes to the practitioner. Any questions, you can get in touch with us. And it's very informative, so much so that the company purchased the report from us as well. So now everyone has access to it, but it's another way, a very informative way of understanding the outcome of your patients that you refer. So just to clarify once more, chronic constipation cases that fail that trial, you think ARM, balloon expulsion testing, because it's thought that there's 50% of these cases out there that are actually functional dysynergic problems, and only 2% are tested with anal rectal manometry. The most important thing is getting these patients the treatment that they actually need. Biofeedback, pelvic floor physical therapy, that's what it's all about, as rapidly as possible. And treatment, you can actually help dysynergia cases in up to 90% of the time. So it's very valuable. And that's actually the end of my talk on anal rectal manometry. And I came up with that. Thank you.
Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. If you would like to work with me personally to help you improve your health, I do accept a limited number of new patients per month for a functional medicine consultation. Some of the areas I specialize in include helping patients with specific health issues like gut problems, neurodegenerative conditions, autoimmune diseases, cardiometabolic conditions, or for an executive health screen and to help you promote longevity and take a deeper dive into some of those factors that can lead to chronic diseases along the way. Please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we'll set you up for a new consultation for functional medicine. And I look forward to speaking to everybody next week.